Hello everyone, so our goal for this video is to find out a systematic way to interpret abdominal x-rays, because usually we interpret chest x-rays systematically using the ABCDE approach. However, when it comes to abdominal x-ray, I find that I can't do it systematically, so trying to find out a systematic way. So here's Geeky Medics Abdominal X-ray Interpretation, written by Daniel Ward and Dr. Lewis Potter. Quite a recent publication, quite recently updated, January 11th. Okay, let's just go straight to it. This guide provides a structured approach to abdominal X-ray interpretation and includes examples of relevant pathology. So first you want to confirm the details. This is the correct X-ray or not. Begin abdominal X-ray interpretation by checking the following details. Patient details, name, date of birth, and unique identification number, date and time the film was taken. Previous imaging useful for comparison. Assess image type and quality. So what kind of image is it? The projection of the image. Assess the projection of the abdominal X-ray. Typical projections of an abdominal X-ray include anterior-posterior supine or anterior-posterior erect. So supine is when they are lying down and erect is when they are standing up. Erect, I would assume it has the advantage of you being able to see air fluid levels in the bowels if there is any intestinal obstruction. And also air under the diaphragm can be seen as well in the erect one, but not the supine one. Okay, exposure of image. Assess the X-ray to ensure the whole abdomen is visible from the level of diaphragm to the pelvis. Okay, so make sure up there is the diaphragm, down there is a pelvis. Exposure. Ensure the exposure is adequate to allow radiological assessment of both the small and large bowel. Abdominal X-rays do not provide a good view of posterior abdominal structures due to the overlying bowel and gas. If bowel perforation is being considered, you don't usually require an abdominal film. Instead, you need an erect chest X-ray, as this allows free gas under the diaphragm to be identified. The patient needs to have sat upright for at least 15 to 20 minutes prior to the X-ray to allow time for the air to rise. Okay, so bowel perforation to a chest X-ray, not abdominal X-ray. Okay, a structured approach to interpretation. It's important to have a systematic approach to interpreting abdominal X-rays, as this decreases the risk of missing pathology. In this guide, we use the BBC approach. B stands for bowel and other organs, second B stands for bone, C stands for calcification and artifact. So the first one is bowel and other organs. It includes a small bowel, large bowel, and other organs include lungs, liver, gallbladder, stomach, psoas muscles, kidneys, spleen, and bladder. Bones include the ribs, the lumbar vertebrae, sacrum, coccyx, pelvis, and proximal femurs. Calcification and artifact, for example, renal stones. Okay, bowel and other organs first. So first, the small and large bowels. Differentiating between the small and large bowel on abdominal X-ray is not always straightforward, but there are a number of clues that may help you. The small bowel usually lies more centrally, with the large bowel framing it. Small bowel's mucosa folds are known as valvulae conniventes and are visible across the full width of the bowel. There's a key difference here. And the large bowel wall features pouches or sacculations that protrude into the lumen, known as haustra, but these in contrast to these valvulae conniventes. In the large bowel, they don't go all the way across. In between the haustra are spaces known as plicae semilunaris. Between the haustra are spaces known as plicae semilunaris. The haustra are thicker than the valvulae conniventes of the small bowel and typically do not appear to completely traverse the bowel. The distinction is unfortunately unreliable, as dilated large bowel can have a haustral pattern that does in fact traverse the bowel. Okay. Feces have a mottled appearance and are most often visible in the colon due to trapped gas within solid feces. Motile appearance of feces, I see. Okay, bowel diameter. The upper limits for the normal diameter of different bowel segments are as follows. You have the 369 rule. 3 is for small bowel, 6 is for colon, and 9 is for cecum. This is often referred to as the 369 rule. So small bowel more than 3 cm is dilated, colon more than 6 cm is dilated, and cecum more than 9 cm is dilated. Okay. So here are some images. A normal abdominal x-ray showing large bowel, white arrow, framing the small bowel. Let's have a look. So this is the large bowel, framing the small bowel in the central area here. I don't see anything here. Oh, okay, I can see a little bit of air spaces here. Maybe there's something inside the bowel, so we can't really see clearly. Okay, so large bowel in the periphery, small bowel in the central region. What does this show? What does the circle show here? Let's look at the annotations first. Example of feces and its typical motile appearance. So, okay, so this is feces. This is the motile appearance of the feces. Okay. This is a picture. The small bowel's mucosal folds are called valvulae conniventes and cross the full width of the bowel. Let's have a look. I can't really see very carefully because of this caption is actually blocking. Oops. It's Haustra. Okay. Valvulae conniventes. You see they're close to each other. All these are valvulae conniventes. It's the small bowel, and this is Haustra. Haustra are thicker than valvulae conniventes. Typically it doesn't cross, but sometimes it does cross. So it's not very reliable to differentiate using Haustra and valvulae conniventes alone. Because this is a Haustra, but you can see very thin over here. It looks like it crosses the whole bowel. Okay. Pilae seminolaris. Plicae. Okay, small bowel obstruction. Typical abdominal x-ray features of small bowel obstruction include dilation of the small bowel, more than 3 centimeters, and much more prominent valvulae conniventes, creating a coiled spring appearance. Okay, is this a coiled spring appearance? Adhesions, the most common cause of small bowel obstruction. Adhesions are the most common cause of small bowel obstruction in the developed world, accounting for 75% of all cases. Some other causes include abdominal hernias and either intrinsic or extrinsic compression by neoplastic masses. So intrinsic compression means the mass is in the lumen. Extrinsic means from outside the lumen, it's pressing inwards. When interpreting an abdominal x-ray, you should always inspect the inguinal regions, particularly if considering a hernia as a cause of small bowel obstruction, as they are often fairly obvious even on plain abdominal x-rays. Is this an x-ray of a hernia? Small bowel obstruction, note the dilated loops of small bowel creating a coiled spring appearance. So you can see, it does look a little bit like a spring. So it is small bowel obstruction. I'm gonna search abdominal x-ray of a hernia. So where is the hernia orifice in the abdominal x-ray? Is it here? Can't really see much here. What is going on here? Swallow some things. Okay, it's like a small bubble in the scrotal area. This one is not adequate exposure. I think you can't see below. can't see the femurs. This one you can see the femurs, but I'm not sure where to look for the hernia. Let's see. Inguinal hernia. Okay. Same picture as just now. This is the right inguinal hernia. Where is it? You know, the eyes doesn't see what the mind doesn't know. There's the left side. I'm looking around this region and I don't know what I'm supposed to see. Is this? It's very vague. This one. Learning radiology, inguinal hernia. Okay. So what's going on here? Let's try clicking into the website. Let's see. There is air, white arrows in the bowel projecting below the obturator foramen. Red arrow. So red arrow is just showing the obturator foramen, and you can see some air projecting below the obturator foramen. So that's your inguinal hernia. Although air in bowel may project in this location in markedly obese patients, the unilateral nature of this finding suggests a hernia. Okay, look for any air below the obturator foramen. That's how you find inguinal hernias. Okay. Right. Next, moving on to large bowel obstruction. The most common cause of large bowel obstruction include colorectal carcinoma and diverticular strictures. Less common causes include hernias and volvulus. Volvulus involves a twisting of the bowel on its mesentery and most commonly occurs at the sigmoid column or cecum. Patients with volvulus are at high risk of bowel perforation and or bowel ischemia secondary to vascular compromise. Typical abdominal X-ray findings in volvulus differ depending on the subtype. Okay, there's the sigmoid volvulus and the cecal volvulus. The sigmoid volvulus, a characteristic coffee bean appearance is seen. Let's see. Is this the one? Yes, so this is a sigmoid volvulus. Where is the coffee bean? It's not very obvious to me. And then in the cecal volvulus, often described as having a fetal appearance. I think Google has better images. I don't see any fetuses here. Okay, let's see if I've seen these pictures before. Yeah, this is so typical coffee bean appearance. It's like textbook picture of a sigmoid volvulus. This is a huge coffee bean. Sigmoid volvulus. So this is your coffee bean appearance. Alright. And then let's look for cecal. Volvulus. Where's the embryo appearance? Is this the embryo appearance? I don't see an embryo resemblance here. Okay, maybe this one, yeah. This one resembles an embryo a little bit. Okay. I don't know about this one. This one resembles embryo. This one is very obvious. This one looks very much like an embryo. It's a sigmoid. The cecal volvulus. Because the cecum is like, remember the threshold for cecal dilation is 9 centimeters, right? It's the widest part of the large intestine even. Is this a cecal or a sigmoid? Looks more like a coffee bean sign than an embryo, to be honest. So this is a cecal volvulus embryo sign. All right, let's look back at the picture here and see if we can identify the embryo. Is this embryo? Why is there a yellow arrow there? Oh, it's just large bowel obstruction. It doesn't say that this is a cecal volvulus. No wonder I cannot find the embryo. So this is the cecum. This is the ascending colon, transverse colon, and descending colon. There's no volvulus going on here. This one, it says it's sigmoid volvulus, but I'm having trouble finding the coffee bean. I don't see the coffee bean. Is this the coffee bean? No. I don't think so. Okay. Okay. After large bowel obstruction, you have also the Wriggler's sign or double wall sign. So in healthy individuals, only the inner wall of bowel should be visible on an abdominal X-ray. In healthy individuals, only the inner wall of the bowel should be visible on an abdominal X-ray. The presence of free air within the abdomen, or known as pneumoperitoneum, can result in both sides of the bowel wall becoming visible. This is known as Wriggler's sign. Causes of pneumoperitoneum include a perforated abdominal viscus, for example, perforated bowel, perforated duodenal ulcer, and recent abdominal surgery. You should look closely for free air under the diaphragm on an erect chest X-ray if you suspect pneumoperitoneum. So this is an erect chest X-ray showing pneumoperitoneum. You can see air under the diaphragm. It's also known as the crescent sign because it looks like a crescent here. And over here, we're supposed to see the Wriggler sign. Let's look carefully to see if we can spot it. You see over here, it looks quite normal because you can only see the inner wall. And over here is soft tissue. That should be the case. However, in Wriggler's sign, you see this wall of the intestine, you can see both sides of the intestine. I think. Let's look, before we jump into wrong conclusions, let's look at Google images for Wriggler's sign. Wriggler's sign. Yeah, you can see both sides. It's like a straight line, and then you can see both sides of the line is gas. It's black on both sides of the line. That's what you call a Wriggler's sign. Let's look at this. Yep. So this is your intestinal wall. Usually you wouldn't be able to see this side so clearly. Being able to see both sides of the wall signifies the Wriggler's sign. Let's look at this one. Come on. Is it not gonna load anymore? Okay. So this is the Wriggler's sign. Okay. And next, you have inflammatory bowel disease. Features of inflammatory bowel disease on an abdominal X-ray include thumbprinting. It's not specific to inflammatory bowel disease, I think, this thumbprinting. Any mucosal thickening. But I guess, yeah, inflammatory bowel disease would cause mucosal thickening. I don't know what else will cause it. Mucosal thickening of the haustra due to inflammation and edema, causing them to appear like thumbprints projecting into the lumen. Let me see if I can find it. I don't see it. Toxic megacolon. Okay, this is not. I'll look for images because it's quite nice to see. Yeah. Yeah. See here. It's very obvious. This is your valvulae conib, and this this is not your valvulae. This is your haustra. Haustra. It thickens to the extent that it looks like thumbprints. Yeah, your haustra look like thumbprints. Okay. Lead pipe featureless colon is of ulcerative colitis. Loss of normal haustra marking secondary to chronic colitis. I think it's ulcerative colitis. Just have a quick Google search. Lead pipe colon. Barium enema finding in chronic ulcerative colitis. Yes, that's the pathology. Oh, okay, I should just show you. It's very distinct. Yeah, you see, normally there are haustras, but over here it's like straight all the way without any curves. That's why you call it lead pipe colon. Right? Never forget this. This is ulcerative colitis. Toxic megacolon, colonic dilatation without obstruction associated with colitis. So this is a picture of toxic megacolon. Note the lead pipe colon with loss of normal haustra folds. This is the lead pipe colon here. There are no folds. Smooth all the way. And it's toxic megacolon here, I guess. Megacolon just means big colon. Okay, other organs and structures. So we've done with the small and large bowels. Although abdominal X-ray isn't an ideal imaging modality for assessing the structures listed below, it is useful to be able to recognize them to help orientate yourself and identify relevant pathology. The lungs. Inspect the lung bases for pathology, for example, consolidation, as abdominal pain can in some cases be caused by basal pneumonia. Liver, a large right upper quadrant structure. That's the liver. Gallbladder, rarely visible on abdominal X-ray. However, you should quickly inspect for calcified gallstones and cholecystectomy clips. Okay, looking for gallstones and clips. Nope, not here. Stomach, visible between the left upper quadrant and midline, containing variable amount of air. Is this the stomach here? No, it's not very clearly seen. Psoas muscles. The lateral edge is marked by a relatively straight line either side of the lumbar vertebra and sacrum. Yeah, this is quite obvious. This is psoas muscle. Sides here. Kidneys. Both are often visible. The right kidney is lower than the left due to the presence of the liver on the right. Makes sense. Here's the inferior pole of the kidney. It's barely visible here. Can't see the right kidney. Should be lower. Can't really see very clearly. Spleen, located in the left upper quadrant, superior to the left kidney. So if this is the left kidney, spleen should be somewhere here. But I don't see it. Bladder has a variable appearance depending on the fullness of the bladder. Where's the bladder? Is this the bladder? Here? Not very sure. Or is this the bladder? Bladder on abdominal X-ray. It's very clear. It's filled with fluids. there's something in the bladder in this person. Okay. Should be somewhere in the pelvis. That's the rectum, not the bladder. Okay. Okay. I don't see it clearly here. Next, go to bones. So BBC, right? B for bowel and other organs. So I've done with that. Bones. The second B stands for bones. I have bad memory. Let's look for it. Bones, yes. Ribs, lumbar vertebrae, sacrum, coccyx, pelvis, proximal femurs. Okay. Bones. Lots of bones are visible on an abdominal x-ray, and it's important that you can identify each and screen for pathology. In addition, bones on an abdominal x-ray provide useful landmarks, which allow you to approximate the location of soft tissue structures. For example, the ischial spines are the usual level of the vesico-ureteric junction. Okay. Bony structures commonly visible on abdominal x-ray include the ribs, lumbar vertebra, sacrum, coccyx, pelvis, and proximal femurs. A wide range of bony pathologies can be identified on abdominal x-ray, including fractures, osteoarthritis, Paget's disease, and bony metastasis. What are the arrows pointing at? Sclerotic bony metastasis. Arrows in a male patient with prostate cancer. Oh, you see the bone here? Over here, the subsclerosis. Over here, it's more white than it should be. Over here as well on the iliac crest. Over here on the sacroiliac joint. It's all sclerosis of the lumbar vertebrae as well. And lastly, the C stands for calcification and artifact. There are various high-density white areas of calcification or artifact may be noted on abdominal x-ray, including calcified gallstones in the right upper quadrant, renal stones or staghorn calculi, pancreatic calcification, vascular calcification, costochondral calcification. Costochondral, isn't that up in the chest? Contrasts, for example, following barium meal, surgical clips, jewelry. Abdominal x-ray showing ureteric stent placement. So there's a ureteric stent. So it goes up the ureter and into the kidney, I suppose. It's a foreign body. Staghorn calculus on the left and multiple renal stones on the right. Ah, so the right kidney is up here. I thought it was supposed to be lower than the left kidney, given the position of the liver is here. So this is staghorn calculus, a really big one in the renal pelvis. This is multiple renal calculi in the right one. Okay, oops, what is this? Belly button piercing, okay. Lastly, how do you present an abdominal x-ray? Having a structured approach to summarizing your findings is key to ensuring you communicate salient points. This is a supine AP abdominal radiograph of Jane Lister, is a pseudonym. Date of birth 11 April 1970. The film is of good quality with adequate exposure. No prior imaging is available for comparison. Both the small and large bowel appear within normal limits. Other abdominal viscera appear normal within the limits of this projection. No obvious bony pathology is identified. No abnormal calcification is visible. In summary, this is a normal plane radiograph of the abdomen. Wow, very sweet and concise. Can memorize this structure. You'll impress your senior. Right. So in summary, you want to approach a abdominal x-ray, like how you approach a chest x-ray, first you need to identify whether this is the correct x-ray or not. So let's try using this x-ray. So first you want to see the patient details, then the date and time this x-ray was taken. You want to assess the quality of the x-ray. Over here, there is inadequate exposure as you can't see the diaphragm. You want to see from diaphragm to pelvis. Over here is enough exposure, but you can't see all the way to the diaphragm. Then you want to look for BBC. B stands for bowels and other organs. So you look at the small intestines. Small intestines doesn't look dilated, it looks normal. Large bowel doesn't look too dilated. You can measure if it's more than 6 cm or more than 9 cm in the case of the cecum. It doesn't look like the large bowels are dilated. And you want to look at other organs. You can't really see the liver very well here. Can't see the spleen. Can't see the psoas muscles as well. Kidneys can't be seen here. Bladder can't be seen very well. Okay, then the second B is bones. Looking at the bones, you can see that's sclerotic lumbar vertebrae, sclerosis of the sacroiliac joints, sclerosis of the iliac crest on the left side, sclerosis of the acetabulum, do you say this? Left acetabulum, and left femur, and small patch of sclerosis on the right femur as well. Overall, there's sclerosis, patchy sclerosis on his bones. And then C stands for calcifications. Calcifications and foreign bodies. You don't see any bladder stones, no kidney stones. I guess sclerosis of the bones count as calcification, but we already covered that. And that's all. BBC. Hope this helps. Thanks for watching and see you next time.